Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to talk about peripheral IV access, its tips and types. As we all know, many a times in the hospital scenario, nurses do faces this technical challenges when they perform, peripheral access and maintain the IV care and therapy. So let us discuss about this. Today we have as an expert panelist Dr. Sree Sowjanya P, who is HOD Emergency Medicine from Yashoda Hospitals, Hitec City. I welcome you, ma'am. And, let me also welcome Miss Ancy Philip, who is our Senior Nurse Manager from Somajiguda unit. I welcome you, Ancy. And let us see what we have in today's session. If you can just share the first slide. As we zoom this slide a little bigger, and as we are looking at the picture, the first slide, yes. As we are looking at the picture, it as we are portraying that patient is just shouting or yelling. I'm sure yes, and they do experience this bitter experience in the hospital scenario when nurses gives them the jab of pain, multiple pricks sometimes, and which is very painful. So my question to you again, ma'am, is like in regards of this needle pricks and doing this IV cannulation, can needle pricks from Venford insertion be avoided if seniors performs this procedure? Because this is all technical skills which a nurse should be competent enough. And you being as an HOD ER, you might be experiencing many of the nurses not able to do this IV cannulation. So what is your take on this? Yes, ma'am.
Yeah. So coming to IV cannulation, which is a lifeline for any patient admitting to the hospital. So we cannot avoid, admit a patient without having an IV access. And coming to seniority, yes, sometimes when the senior nurse is available, they can perform and they can do the technique with ease and avoid multiple pricks to the patient.
Okay.
And one most important thing here is to avoid needle prick injury to the nurses also is important. Again, it depends upon the technique how the nurse is using. And some Venflons are coming now with pro safety Venflons where the needle doesn't come out.
Yes.
That will help in avoiding needle prick injury to our nurses as well.
As well, yes. So let us see what we have in rest of the session. Over to you, Ancy.
Good morning, myself, Ancy. Let us know what is peripheral access. Peripheral access or intravenous access. Intravenous itself says into the vein. A catheter or a cannula which allows the substance to flow within. So, do you think it is required? Yes, it is required. It helps in transfusion of blood and blood products. It helps in administration of anesthesia, high-risk medications like chemotherapy drugs, and even it helps in radiological imaging by using IV contrast.
So as madam, you said, and we all know that, a patient comes to the hospital and the insertion of IV cannula, sampling, ABG analysis, everything becomes an interventional lifeline procedure for the patients. Yes. So in terms of indwelling, when we talk about indwelling, what is, the mean of a real indwelling catheter means in just short? Yes.
Yeah, indwelling catheter is, as it is already mentioned, which is kept, a catheter or a sheet which is inserted into the veins where it gets along with the blood circulation, and whatever we are transfusing or infusing through that catheter goes along with the blood and reaches the circulation at a faster rate. It reaches the required site of action very fast because blood flows within the body at a very fast rate, at around 72 times per minute it beats. So it helps in reaching the circulation very fast. That's the reason why we use intravenous or indwelling catheters in the hospitals.
Yes. Yes. And
so, what are the types of peripheral IV access? The first common type of peripheral access is short peripheral catheter. It is also known as the over-the-needle catheter. The catheter which is attached with a needle, we insert into the vein through the skin. So, as the picture shows, these are the metacarpal veins. These are the metacarpal veins, basalic vein, cephalic vein, median cubital veins, and radial veins. Radial veins, we must not prick for radial vein, or we must not go for radial vein, as we all know that behind the radial vein, we have radial artery. So we must avoid radial vein. Next, external jugular vein. External jugular catheter are inserted in the major superficial vein that is located in lateral side of the neck. When the patients, we won't get any access in the peripheral sides, in a peripheral area, hands or arms, so we usually go for external jugular catheter. Middle line catheters. Midline catheters are 3 to 8 inch length. It has 3 to 8 inch length. It is inserted with the help of ultrasound into the vein, typically into upper arm, that extends to the level of axilla or above.
So here we would like to ask you, Ancy, if the external jugular vein catheters are also being placed by the nurses sometimes when we do not have IV, metacarpal and dorsum area available. So do
Yes.
you educate the patient pre-procedure that neck mobility is not an issue because the gaze of the catheter is going to be very small? So patient
Yes,
might
ma'am.
assume ki, I don't have to move the neck and all. With this fear, he might be just restricting his neck movement. Do you educate?
Yes, we do educate, ma'am.
Yes.
Do educate the patient, like you should be very, it's not, might be like difficult.
Yes. And ma'am, again, we would like to also have your insight, like the usage of midline catheter. What are the indications? Like maybe a patient comes to ER, maybe the peripheral access are very well fine, but then still there's a selection of doing the midline catheterization. So what is the utilization?
Yes, when it comes to peripheral vein catheters, they need to be changed every 48 hours because of the risk of infection and extravasation. And when we anticipate that the patient needs prolonged IV antibiotics or IV fluids, or sometimes parenteral nutrition to be given, we may have to go for midline catheters. And that's the reason why, whenever there is a prolonged requirement of antibiotics, we chose to put midline catheters. And once the usage is over, we can remove them, and the healing becomes very fast.
Yes. And we might also switch it to the peripheral line.
We might switch back to the peripheral line once we are weaning off the patient or the patient is improving from the illness.
Beautiful insight, ma'am. Yes. Yes, Ancy.
Yeah. Intraosseous access. Intraosseous access is generally considered safe and effective in emergency situation into the bone marrow with the help of gun and needles. You can see in the image. It is usually used for pediatric patients.
So here, the rare kind of this procedure, intraosseous, I have not witnessed in my clinical, scenario. Maybe I used to always assume that this is only done for the orthopedic, prolonged pain medication, thing. Maybe other learners are also might be having this kind of, psychology and phenomena as well. So when is the intraosseous route, indicated, ma'am? And nowadays in current scenario, do we use this, site in form of any kind of procedure?
Yeah. Coming to intraosseous, yes, I do have a lot of experience in IO accesses. The reason is most of the pediatric age group, when they present to the emergency in either cardiac arrest or severe dehydration, getting a peripheral access is very, very difficult in them. So that's where we use IO access, especially when the patient is in cardiac arrest. We cannot wait for searching for a peripheral vein. We go for intraosseous access, which is a temporary access. But once the fluid volume restored and the patient is resuscitated, we can always switch back to peripheral access.
Yes.
It's not that difficult as we always think that, the minute we say intraosseous and it's something related to bone, many of us get the fear of inserting it. But with the help of the guns that are available now, it is very, very easy to insert and very, very life-saving as well.
So kind of kit we, see and assume
Yes.
that it is going to be just perforating the vein and then it is going to be painful is the thought process. That's it.
Yes, yes.
Yeah, see.
Yeah.
back, you can just talk. Yes.
Selecting the peripheral site for cannula. Selection of the peripheral site begins with the sites we select and the site we select for the cannula. It is done by the skilled nurses only. What are the tips and what are the selection criteria for a successful IV canalization? First of all, patient assessment. Patient assessment, we need to see the factors like age, why the cannula is required, which type of treatment we are going to give. For example, blood transfusion, which type of, which size of catheter is required. Any previous history of peripheral access. Do patient have any surgical limb, AV, fistula, mastectomy limb? So we should always take a thorough history from the patient. Selection of vein. It begins, selection of vein. It usually begins with the visual inspection. Visual inspection is nothing. Visualizing the patient arms, hands, other potential sites for IV access. Is the vein is straight, prominent, without any sign of discoloration, swelling, or inflammation? Palpation.
Yeah.
Next
So
is
very well said. All this point is clearly indicating that nurses should do this, assessment upon admission. It is
Yes.
no point of doing after, cannula prick, you have done the cannula and a lot of time you're picking the patient. After that, you're taking this history and all. So I request all the nurses to do this assessment upon the initial admission of the patient, whether it is a transfer in, transfer out to the new ward or to the ICU. Yes. So,
Yes.
ma'am, again, we would like to understand from your point of view, these points which has been indicated by Ancy, are these enough or you would like to add on something else?
Yes, she has covered most of the points that are required, and one or few lines is when there is a fractured limb, we ask them to avoid IV peripheral access into that vein and into that limb, and when there is hemiplegia or paraplegia, we avoid because the circulation will not be effective in those limbs, so we avoid in those things. So, and and in CKD patients, we avoid pricking the left hand, and in cardiac patients, we avoid pricking the right hand.
Because
So
of
this is the tip that many of us can remember.
yeah, and we nurses bound to forget this because of,
Yes.
rush.
In the stress, they forget.
Yes. So we request everybody to just keep these clinical, contraindications in the mind before you do the
And one
catheterization.
more most important that we need to remember and emphasize is avoid placing the Venflon into the joint spaces.
Yeah, acromion, yes.
Yes.
Because again, the mobility and
Mobility,
is the
yes.
issue, and then kinking will take place very soon. Yes.
Yes.
Nancy?
assistive devices for vein flow. As you see in the picture, it is called as vein scanner or vein finder. It is a medical device used to visualize and localize the vein beneath the skin. It is a technology used near infrared rays. Next is ultrasound guided IV access. It is widely used in a clinical setup in emergency department, ICU care, operation rooms, outpatient clinics. It facilitates safe and effective vascular access for intravenous therapy, medication administration, and blood sampling also.
So, ma'am, this technology is in terms of vein detector and a very good method of ultrasound guided cannulization, especially for ICU bed-bound patients. If 20 decades back, if it or sorry, 20 years back, we did not have these technologies, but these are good technologies in place nowadays. So, use of these technologies, does it reduce the pricking incidences and a lot of patient comfort is being gained in the hospital scenario? What is your insight on this?
Yeah, these new technologies are very useful, but again, expertise is required in using these technologies. When it comes to IV finder or IV scanner, which uses near infrared technology, which will help us to locate the veins, we have to be careful in identifying which is a deeper vein and a superficial vein. So it becomes very difficult to cannulate a superficial vein, though it is seen like a straight line to us. So that's where the expertise of the skilled nurse is required to identify which vein to be chosen.
Yes.
And similarly, when it comes to the ultrasound guided, yes, it is very useful in the ICU setup and even in the emergency room, wherever we have to go for central venous catheters and peripheral midline catheters, where we want to insert into the larger veins, which will stay for a longer duration. Again, expertise is required, because if you don't use the appropriate pressure of the ultrasound probe, you might obstruct the vein itself. The vein is easily collapsible on ultrasound. So you need to you need that expertise to understand the amount of pressure you need to put, so that the vein is not collapsed underneath and you are able to visualize it properly.
So yeah, I get to see the ICU nurses along with their doctor and clinical intensivists. They keep doing this,
Yes.
this try to visualize. I think the
Yes.
practice would do this, justification that they should practice by, just
Yes,
by,
definitely. Both for scanner and ultrasound, practice is required before they attempt on the live patients.
not only assist, please assist, do watch your clinicians and just take the required competent skills so that your
Yes.
patients are safe and you're all safe too. Yeah.
Securement and dressing is also an important aspect. If we are not secure or dressing is not done for the cannula immediately, the cannula can get displaced or it can be dislodged. Intermittent flushing should be done. Nowadays, we have pre-filled Heplock solutions or salines for flushing. It is available in the market. The most important aspect is scrub the hub before use. We must use alcohol swabs before administering any medication in a circular form.
So, Ancy, my question again to you is, do you all scrub the ports or hub before you, even try to insert the IV cannula or infuse any kind of, infusion? Because as you all know, this, scrub the hub is very important because CIBSI is the single factor for this, for this contamination and aseptic technique while we perform the infusions. So, do you all do this bedside practice?
Yes, ma'am. We used to practice this in our institution.
Yes, yes. That's very great practice. I think everybody, the learners and the viewers, we must anytime when we want to connect the, IV lines and all, and before we insert the syringes, we need to scrub the port and hub anti-clockwise, not only syringes, even central lines and PICC lines, all the catheter supports and hub. Yeah. Next.
Stress balls. Can you believe stress balls will help us? Yes, stress ball will help us. Gently squeezing of the stress ball can stimulate blood flow and venous filling in the hands and arms, potentially making veins more prominent and accessible for canalization. We can educate patient when they get discharged, like oncological patients will be there. They will be posted for some or another chemotherapy. So we need to educate them. They can use in home regularly the stress ball, which helps in the veins to get prominent.
So, ma'am, how effective are these stress balls in promoting, effective venous sufficiency? Because I used to see sometimes, oncology patients, and sometimes they sit in the waiting area and they do the squeezing technique. Even nurses, before they insert the cannula or do any phlebotomy, they ask the patient attenders, patients to squeeze their arms and hands so that we have enough for venous sufficiency. So, what is your take on this, ma'am?
Yeah, the movement that we are providing at the hand level will help in increasing the blood flow to that particular area, and there will be increased venous filling. So sometimes, even if the vein is not seen at the first instant, after 10 or 12 squeezes, we can see the vein prominently, and that's really helpful. And as it is mentioned, that some chronic patients who require to take these required to get their peripheral accesses done repeatedly,
Yes.
making them do the stress ball exercises is very, very useful. It will help in avoiding those hard veins as well, because the blood flow will itself will heal the veins.
Yes. So I think nurses are also should understand that these are going to be a time-taking process. One must not in a hurry to just do the peripheral IV canalization. By looking at these contraindications, you must really spend your time, have your right kind of body mechanic, take the chair, sit, and then parallel to the patient, and then do the cannulation. I don't think there will be a failure attempts. Yes.
And most important is we have to communicate what we are doing to the
Yes.
patients when they are conscious.
Yes.
So
Yes.
that gives them a lot of confidence in us
Okay.
that we are doing a right procedure for them.
Yes, and they start cooperating with us. Yes. Yes, Ancy,
So
what are the slides you have? We are going to talk about this images.
Yes, we are going to talk about the images to prevent multiple pricks. Like usually the patient are nowadays, they complain about multiple pricks. So we must avoid this all sides. The tortured veins. The first picture it shows like tortured vein, used vein, the bulbs. So we should not prick this all lines for any sampling or canalization.
So, very prominent complaint which we received from the patient is Anni Bagundi, Kani. The prick pain was bothering us, and it kept bothering when they have gone home also. So this is the very prominent complaint which we keep getting. So nurses, and if you just go to the previous slide, if nurses, if you see these kind of images, sorry, these clinical indications, do not pick the sites. It is not that we find one little centimeter of vein and then we try to cannulate from the other core or angle. We must not use these sites because multiple pricks are something which is very bitter experience, which is spoken by the patients and attendants, and it also talks about the hospital repute. So please avoid this and let our patient go safely and with happier outcome. Yes.
And I want to add one more point.
Yes.
Another practice, what we see is we keep on trying on the same vein in the same site if there is no backflow is properly not achieved. So what happens is you might achieve backflow and think that the venflon is within the vein, but there is extravasation that is happening as well because of double prick that already happened to the vein, which will cause a lot of pain and swelling to the patients. So they should be very careful that in one prick they are not getting it. Avoid that and choose another vein to cannulate is better than trying on the same vein for a longer time.
And if you have done one attempt also, make sure that you explain, the
Yes.
anatomical position and clinical indications to be explained to the patient. Give them some kind of warm or cold compression so that the pains is better taken care. That's how we need to manage this local pain formula to all the nurses. Yeah.
Moving forward,
Yes.
nurses must assess IV access daily. In every shift, she must check. And even we have the practice of documentation in our institution. So if we will daily check in these 3 shifts, so we can reduce the chances of phlebitis, infiltration, catheter dislodge, occlusion, and when to reside the catheter. Patient may complain pain, redness, tenderness, and it will lead to patient to the sepsis also. So we must assess IV access daily.
So, ma'am, here, what types of drugs are associated with this common condition called infiltration? Sometimes we must have traumatized the vein, or maybe we are just going to infuse the irritants or vesicant or non-vesicant drugs. And what immediate precautions to reduce the potential, complications or pain the nurses should adhere to?
So any drug can cause infiltration once it is double pricked and can cause local systemic changes will be seen. And we have seen even the worst complications are seen with drugs like inotropes, noradrenaline, adrenaline, then potassium chloride, very toxic and can of the skin if it is gone into the subcutaneous plane. And even 25% dextrose, which is life-saving in terms of hypoglycemia, if it extravasates into the peripheral tissues, it causes a lot of pain and swelling. And all chemotoxic drugs, chemotherapeutic drugs, are known to cause very high chances of infiltration and complications associated with it. It can lead to gangrene formation. It can lead to infections, and a lot of debridements are required to treat these patients once it happens. So most important, once the venflon, as well in the checking itself, when you find there is pain or redness, we have to change the venflon without any second doubt. And sometimes the most important indication is the flow of the venflon is not appropriate. Again, is an indication, even if the patient is not complaining, but the flow is not appropriate. That's the first sign that we can identify that there is something wrong with the venflon, and we should change to another venflon and get a new venflon done for the patient instead of going to the same vein.
So very valuable point. We nurses sometimes they just keep looking at the drop, but then they do not try to change. Yes, and by the end the gradual cessation of drop happens. So we urge nurses to just take the point which has been spoken by ma'am just now. Yes, as
So, when to recite or when to remove a cannula? Like how do we understand the cannula is not working? So we have a best tool that is called as visual infusion
infusion.
phlebitis score, VIP score, that starts from 0 to 5. It
So
tells
here, yes. So here, this guideline is a printed copy, and it is a part of our case sheet, where also a fresher nurse versus the senior nurses also should not get confused. They know when to recite the cannula, because right from the IV site appears healthy. When if you can see the column here, the no signs of phlebitis, you need not to worry. But when you see little bit of slight pain at IV site takes place, you need to start your precaution right from there. So we tell all nurses these are only 1 to 5 categories. We only decide the cannula right from the second score, don't we? And see, yeah, early stage of phlebitis starts at stage 2 only. So
yes.
nurses should remember this, not to go to the till the third stage. We need to only recite right from the second stage. So these are the beautiful guidelines which is there as a part of case sheet. Nurses should see, take the evidence-based phlebitis role, and then they can recite before phlebitis occurs. Yeah, so we want all the nurses to practice this. Yes.
Like morning shift, we have general shift, so nurses might have leaders, senior nurses in that time. So in the evening time when patient comes, whom should they call for help? In case any difficult canalization, ABG or sampling is there, we must avoid pricking multiple times. We can call for help our supervisor. Evening supervisor will be available if she is enough competent. If she is not competent, you can go with EMT technician, senior nurses, duty anesthetist.
So,
This
ma'am, I think, yeah, we would like to also talk that not only multiple pricks, I know the patient body is not something which we nurses are going to test and try. Before we, start doing the prick, first we need to inspect, I think. Then only we can approach these hierarchy. Yes,
yeah.
ma'am?
Yes,
Yes.
agreed.
Yeah. Yes, Ancy.
What are the drawbacks of this? Local infection. Local infection can lead to inflammation, cellulitis. Patient may go into sepsis. If we will not follow, catheter-related bloodstream infections can occur, and it may also lead to hand amputation. So we must see and follow catheter-related bloodstream infection bundles.
So, ma'am, this is one of the very worst and adverse event which can happen with the patient in terms of extravasation. I used to always see, right from the CT imaging department, when the injector, forcefully injects the contrast media to the, IV. So, and then patient may just go, normally, but then delayed extravasation with the complaint of delayed extravasation, hematoma, redness, they used to come back. And again, we used to do some ultrasound guided IND. So what is your, point, your take on this, and how should we prevent this?
Yeah, extravasation causes lot of complications, as we already mentioned, that it can raise from compartment syndromes where the internal pressure of the hand increases, or there can be cellulitis, or there can be a swelling which is a long-standing swelling which looks very awkward for the patient. These are all the minor complications, but the major ones can be hematomas or gangrene formation because of some drugs like IV contrast or IV noradrenaline or adrenaline can cause gangrene formation of the peripheral distal to the venflon injection, and may lead to amputations as well. So we have commonly seen digital amputations and hand amputations because of gangrene formation, which is secondary to extravasation of certain drugs. So we have to take every precaution right from insertion of the IV cannula to the maintenance of IV cannula. We have to be very, very careful about extravasation of any drug. Even an IV fluid, if it is extravasated, it can cause swelling and can be painful for a patient for a very long time. Though there is no systemic, reactions or inflammation like other drugs, but even an IV fluid extravasation also is a painful experience for the patient. So we have to be very careful and take all the measures that are required to prevent extravasation from the peripheral catheters.
Yes. So do you also, suggest the nurses whenever they see these symptoms to just aspirate the particulate and then provide some warm compression just to get the immediate relief? Or depends on the, substances which has gone into the body, ma'am?
Yeah, to some extent it helps in withdrawing the pressure.
Yes.
Especially when there is a severe swelling is there, or we are knowing that the patient is going for compartment syndrome, definitely there is a role for giving that warm compression for certain time. But getting an expert opinion is very, very important. Maybe we have to involve a plastic surgeon or a surgeon at the earliest, so that the further complications can be avoided. If the patient is going for gangrene formation or compartment syndrome, we have to deal with it at the earliest rather than keeping it. Most of the time we have the fear that it is related to IV cannula. What will the patient say? What will the doctor say? Or what will the family tell to us? So that fear should be avoided and do what is best for the patient, even if a complication happens.
So we must always, these are a little underrated, under notified incidences. I think we must bring this kind of incidences out so that patients, should not have the salvage of any limb or something like that. Yes. I think we have come to the end of the discussion. Nancy, we would like to talk about the, conclusion. Yes, IV Venflon, phlebotomy, ABG analysis, all kind of tricks and, procedures are very, very important. And we nurses in the hospital scenarios, so we are supposed to give a gentle and painless prick to the patients. This is only the, end of the session, and key nursing skills to learn, practice and execute it effectively. If not, please do not multiple time you prick the patient. Before that, you can just escalate and call the seniors in the scenario. And I think this is little going to be helpful seminar for everybody. And we end the session. Thank you, ma'am, for your very valuable time.
Thank you.
And
Thank you so
thank
much.
you, Ancy. Thank you, ma'am. We end the session.